Over the last 12 years, the Department of Radiology at the University of Florida College of Medicine has conducted a simulation-based evaluation of radiology resident competence in critical care imaging. 345 residents interpreted this case of subperiosteal abscess as one of 65 cases during an 8-hour simulated on-call shift, with a median score of 4 out of 10 and an overall average score of 4.17 out of 10. Overall, the average number of points lost out of 10 to observational discipline was 3.49. At the same time, 2.35 points were lost due to interpretive errors on the part of the residents. We define an effective report to be one which achieves scores between 7 and 10. In terms of letter grades, this would be an A or a B. In this most missed case, 11% of residents produced effective reports. We define a report having a critical error to be one with scores between 0 and 2. In terms of letter grades, this would be an F or a D. In this most missed case, 18% of residents produced reports with critical errors.
MR images in a 15-year-old with right knee pain. There is increased T2 signal and geographic loss of T1 signal and the distal femoral metaphysis. There are similar marrow changes in the adjacent epiphysis. There's also heterogeneously T2 hyperintense collection centered deep to the periosteum along the posterior aspect of the femur. This demonstrates peripheral enhancement. There's also a moderate joint effusion with synovitis. There is surrounding soft tissue edema. Together, these findings are concerning for hematogenous osteomyelitis in the distal femur with associated subperiosteal abscess and septic arthritis. We should recommend emergent orthopedic consultation. This case should be given an acuity ranking of emergent, and the findings should be communicated to the referring provider. So this is a classic appearance of hematogenous osteomyelitis in a pediatric patient. Hematogenous osteomyelitis has a well-described pathogenesis. First, a traumatic osseous contusion engenders hyperemia to repair the damage. Frequently, the injury is very mild and the patient does not even recognize the trauma. At a later point, there is transient bacteremia, which is often unrelated to the trauma. Potential causes of this transient bacteremia include an unrelated mild soft tissue injury or dental manipulation. The bacteria then seed the bone that is already hyperemic. Typically, the metaphysis is involved because the blood vessels here are numerous, tortuous, and fairly slow flow. This configuration of blood vessel is helpful to deliver nutrients to rapidly growing bone, but also anatomically predisposes to bacterial seeding. Incidentally, this is why the metaphysis is a common spot for metastatic neoplastic disease in the pediatric patient. If the patient's immune response cannot control the pathogens, then an osteomyelitis is established. As the osteomyelitis progresses, the disease process can decompress through an adjacent metaphyseal cortex. If the metaphyseal cortex is extra-articular, then a subperiosteal abscess can develop. If the metaphyseal cortex is intra-articular, then a septic arthritis can develop. In this particular case, the posterior cortex of the distal femoral metaphysis is outside the joint capsule. Hence, we have a subperiosteal abscess. Anteriorly, the metaphyseal cortex is within the joint capsule, resulting in septic arthritis. In these cases of osteomyelitis, be it in the diabetic foot, next to a pressure ulcer, or in the metaphysis of pediatric patients, we should assess the degree of enhancement in the involved bone. We expect marrow enhancement with osteomyelitis. Decreased marrow enhancement may indicate impaired vascularity, which would decrease delivery of oral or intravenous antibiotics.